Second section is a little less complicated, so we hopefully will be able to get through it fairly efficiently here, and I'll be happy to answer questions afterwards. The specifics of children's trauma are what makes the skeleton of the child a lot easier to deal with. Is they heal quicker. They're much less likely to develop contractures from a long arm cast, for example, and they can remodel. The picture you see on the right here, they can take a almost 90-degree angulated humerus and through just normal growth, grow that deformity away. The basic principle that doesn't change is that joint fractures that go into the joint that are interarticular need to be treated surgically and have to be reduced as anatomically as possible. Child abuse I have to talk about because it's for sure asked on the test. It's for sure the least favorite part of my job, taking care of kids. I can't stand seeing child abuse, but it's just a fact. From a testing standpoint, what you need to recognize and not miss on the test are make sure that if there's multiple fractures, typically classically it's multiple fractures, various stages of healing, corner fractures, such as the metaphyseal angle, the proximal tibia or distal fibula, multiple bruises about the back and chest, unreasonable stories, and any long bone fracture in an infant. By definition, at Children's Hospital in Denver, any child that's not walking that presents with a femur fracture automatically has to have a child abuse workup. If you're not walking, it's pretty hard to break your femur unless you roll off of something, which can happen. But in general, you need to be suspicious enough that you test more people to make sure there isn't child abuse as opposed to letting them slide. The treatment for the injury is easy. You treat it as though you would any other fracture care. But the real answer you need to know is that if there's something, for example, if they show you the 6-month child presented with a femur fracture, and it's an oblique spiral femur fracture, I mean, they're going to have spica cast, all this other stuff, and the real answer is going to be probably section E, which is obtain non-accidental trauma consult or social service consult or further evaluation. Physeal fractures in children are something that you need to know about that are specific to kids, obviously. The typical area where the fracture occurs is the zone of provisional calcification, and that's because you have this hypertrophic zone of cartilage cells that are relatively pliable and flexible, and then the zone of provisional calcification, which becomes relatively more rigid, so it makes a nice cleavage plane, and that's where the fracture occurs. The distal radius is the most common, and the Salter-Harris fracture classification is the one that's utilized on the test exclusively. The treatment for physeal fractures, the vast majority of them are treated with closed reduction and casting because the vast majority of them are distal radius fractures like this one. Anything that's interarticular, Salter 3 or Salter 4, for example, you might have to reduce them open and pin them or fix them some way to restore joint congruity. Severe open injuries, just as they are in adults, you need to do the irrigation and debridement, probably the most important portion of the operation. And then try to do a disarticulation if you can. This slide and the next one sort of depict the sort of obnoxious example of that. But this child had a diaphyseal transection, and the worry with doing diaphyseal amputations are that you get overgrowth, most commonly in the humerus, if you have an amputation through the mid shaft of the humerus. This child had these missing parts phenomenon, so we turned back the proximal tibia and attached it to the femur, and the microvascular folks reattached it so that we could have I mainly did it as a demonstration. You want to have a disarticulation if you can at all possible, because that won't overgrow. And if it doesn't overgrow, then that child likely just needs that one operation. If this child was, I think, 4 years old at the time, and if I do a diaphyseal femur amputation, I just guarantee him he's going to need 3 or 4 more operations to do the repeat amputation for his overgrowth issues. The other things that can happen with specific to kids or with physeal fractures in particular, they can get physeal arrest, obviously. If you break through the fracture, fracture goes through the physis, it can shut down the physis. It can either be complete or partial. Complete physeal arrest will cause a length discrepancy purely and no other problems. A partial physeal arrest, like you see on the right here, will cause an angular deformity. Had a medial proximal tibial physeal arrest and created a varus deformity about the proximal tibia. The treatment for the physeal injuries or the physeal bars depends on several things. The most important thing from a test standpoint is you have to have these two issues to make it worth considering treatment. For example, if you have a child that's 17 years old and almost done growing, it's pointless to go in and try to do a bar resection because they're almost done growing. So you have to have greater than 2 centimeters of growth remaining, and you have to have less than 50% of the physis involved. If you have greater than 50% of the physis involved, you're going to be scraping out the bar and there won't be enough physis there to regenerate the growth cycle. So you have to have those two factors in order to reconcile a bar resection as your treatment. If it's greater than 50% of the physeal involvement, 75% let's say on a distal femur for example, the best answer is probably to go ahead and just do an ipsilateral completion of the physeal arrest, and then possibly a contralateral physeal arrest if there's a lot of growth remaining, so that the legs are the same length when they're done growing. This particular example, you can see a child with a Salter 2 fracture of the distal femur. They went on to a physeal arrest that you can see in this picture. 11 years old, so has this is a male, has 5 years of growth remaining at least. Rule of thumb we talked about earlier today, 9 millimeters of growth per year. So 5 times 9, he has 4.5 centimeters of growth remaining in that distal femur. So we made a window in the did a bar resection, made a window in the distal femur, came down and resected the bar, and this is, as you can see, 9 months later. After you take the bar, which is essentially a tether across that physis out, the remaining physis can then allow it to continue to grow, and hopefully in a non-angular fashion. So the next section I'm going to go through, for the rest of the trauma section, I'll go through specific body parts. So the biggest thing I want you to remember on the trauma, anytime you see any broken bone on your board exam, make sure there's not a physis, or if there is one, that you notice it, because the treatment will be definitely different. The treatment for a both bone forearm fracture in an adult my age, it's displaced, everybody knows you're going to fix it. In a kid, that's not going to be the answer. The kid, if there's an open physis and the kid's 10 years old, it's closed reduction and casting every time. So keep that in mind. Make sure you notice that there's a physis, because they will definitely have those back-to-back on the test and have those questions back-to-back. So starting at the distal radius, if it's extra-articular, Salter-Harris fracture, a closed reduction and a cast, 99% of the time that's how we treat these. Intra-articular, if it's a Salter 3, which is unusual, or a Salter 4, which is also unusual, if it's displaced, we'll do an open reduction just like we would for any other intra-articular fracture. Buccal fractures or torus fractures are treated in a cast without a reduction. And green stick fractures that are just one cortex broken and the other side is bent, sort of like a green tree limb. If it's greater than 15 degrees angulation, we'll do a closed reduction. If it's less, we'll treat it just in a cast as we would a torus fracture. This is a classic example of one they'll show you on the test, and you better make sure you see the physis. If that's a 20-year-old, I guarantee you the treatment's different than in this 12-year-old. In this 12-year-old, the answer for this 100% of the time is a closed reduction and a cast. And this is the closed reduction in the cast. You can see goes on to heal with reasonable alignment and minimal downsides. Once again, we can treat it in a cast because they don't get stiff. They have good thick periosteum, which holds the reduction, and you don't need to treat that with pins. There are obviously exceptions, but they don't typically ask you the exceptions on the test. They want you to recognize that it's a kid. In this forearm fracture, anytime you see an ulna fracture, they never show you the elbow. And so they'll show you this x-ray that stops right here. Displaced ulna fracture and the radius looks to be intact. If they do that, then obviously the next answer is x-ray the elbow. If they show you, because you want to make sure the radial head's not dislocated. This is another one in a child that's treated differently than an adult. Commonly we'll have an angulated ulna fracture and the radial head will be out for a Montesia variant. And very commonly we can treat that with a closed reduction. The radial head will spontaneously reduce and treat it in a long arm cast. In adults, almost always that's a fracture of necessity that needs to be treated operatively. In this child with this type of displacement, most time we have to treat it with an intramedullary nail, but I always try a closed reduction first. The Galeazzi fragment typically happens in the older adolescent, closer to skeletal maturity, and therefore is treated more similarly to an adult, where commonly we have to do an open reduction and at least pin or some type of stabilization for the distal radial ulnar joint. Supracondylar humerus fractures, I have not seen one test that didn't have at least 2 questions about supracondylar humerus fractures on the test. It can be the bane of your existence because they never happen during good time. It's always dark or some odd hour. And it happens from a fall on an outstretched hand. The categories for classification are type 1 is non-displaced, type 2 is the posterior cortex is intact, and type 3 is the category that's too large by most of us to take care of these, we think. This is a type 3. It's also a type 3 if the cortex of the posterior humerus is fractured but still minimally displaced, so it's too broad of a category. The bottom line is if it's a type 2 or a type 3, it needs to be treated with a closed reduction and pinning. That's the CRPP, closed reduction percutaneous pinning. I would say at least 95% of the time it can be done closed without opening the fracture. Anterior interosseous nerve is the most commonly injured nerve. And extension type is far and away the most common, 95% plus. The treatment is closed reduction pinning. They won't make you pick whether you're going to do cross pins or lateral pins, but there is definitely literature support in the last 2 years in the Journal of Bone and Joint to support the concept that biomechanically, cross pins is the strongest, 2 lateral pins is the second strongest, and so biomechanically that's okay, but in fact, in reality, in treating it, I almost always try 2 lateral pins first and then assess the stability. If it's stable enough with 2 lateral pins, I'll leave it at that. If it's not and there's room, I'll put a 3rd lateral pin. If there's not, then I'll put a medial pin. So it all depends on what you need to get sufficient stabilization. The complications associated with supracondylar humerus fractures, varus malunion from malposition of the fracture. These are commonly rotational issues. Creates a gunstock type deformity. Nerve palsies, knock on wood, I've never seen a nerve palsy that was traction related to the injury not resolved. Commonly it takes 4 months. It can take a long time. Open injuries that happen can have direct nerve lacerations and can be more severe. And then obviously vascular issues are a valid concern. I'm going to go back to that slide one more time, I'm sorry. The question they like to ask you on the test is if you have a child that has something with vascular compromise. If they come in with a pulse, you go into the operating room, you reduce it, the pulse goes away, that's the easiest answer. Something's tangled up in the fracture, you must undo the fracture, get the pulse back. No question about that. The one that's more difficult is if they come in without a pulse, but they have good capillary refill and a warm, perfused hand. You do a reduction and you still don't have a pulse, but the hand's still perfused, warm, and has good cap refill. That most likely is spasm, and the answer to that is as you check your x-ray, make sure there's not a gap, meaning to make sure there's not soft tissue interposition at your reduction site. But typically we'll warm the room up, apply warm water to the limb, see if you can get the spasm to go away, and then that you do not need to take that one back down. Lateral condyle fractures, if it's non-displaced, can be treated closed in a cast. I think it's harder to follow. Those are harder for me to treat than they are the ones I open, because the ones I open I put a pin in and I know it's stable and I don't have to worry about them as much. The non-displaced ones you have to watch like a hawk. I usually see them every 4 or 5 days to make sure it doesn't displace, because it is intra-articular. And it is a very large fragment. In this depiction you see in the picture here, you have a large epiphysis of the lateral condyle so you can see it. But commonly these kids are 3 years old and their lateral condyle may not be ossified. And you'll see just a flake of bone and it looks like, oh, it's not a big piece, but it's a huge piece. It's half the elbow joint. And so if it's displaced at all, it needs to be treated with open reduction and pinning. And usually we use pins that are smooth that go across the epiphysis into the proximal humerus. This is an example of a displaced lateral condyle. You do an open reduction. The biggest thing you need to do when you're doing the reduction from a surgical standpoint is stay away from the posterior aspect of the lateral condyle, because that's where the blood flow comes from. If you take out the posterior aspect of the soft tissue, you will devascularize the fragment, and that is obviously not good. So you do an open reduction, you leave the posterior portion of the soft tissue attachment intact, and do your percutaneous pinning. So that I usually leave the pins outside the skin so that I can pull them out in my office, but that's more personal preference than it is rule. Medial epicondyle fractures. There's a recent article in the Journal of Paediatric Orthopaedics titled, "Should You Ever Fix a Medial Epicondyle Fracture?" I think the only definitive answer on the test as to when to fix a medial epicondyle in a child is if it's entrapped in the elbow joint. Everything else is a relative indication. 99% of them are treated non-operatively, but on the test they seem to ask you the entrapment question. For that reason, I'll show you an example how it happens and what it looks like on an x-ray. They get a valgus stress typically to the elbow, which pulls off the medial epicondyle, and as the elbow subluxates, that can then be infolded into the joint. The typical way they'll say on the test is this child came in with an elbow dislocation, had a reduction, and here's the post-reduction x-rays. How do you want to treat it? Obviously, they don't put the arrow on there, but you can see that there's a little bit of ossification within the elbow joint, and it's a wide reduction. It doesn't look stable. That's the medial epicondyle that's entrapped within the joint. The treatment for that is this, to pull the epicondyle out of the joint. And that's the one and only time that I would say on the test that the answer would be to do the reduction and fixation of the medial epicondyle. Radial neck fractures. From my personal standpoint, I don't like these injuries because they cause a stiff elbow, much more so than any other elbow injury I see in a child. In general, on the test, if it's less than 30 degrees angulated and minimally displaced, it can be treated non-operatively in a splint or a cast. Between 30 and 60 degrees of angulation, do a closed reduction or attempted closed reduction and cast. If it's greater than 60 degrees, you have to do an open reduction. And typically, on the test, they'll want you to put pins in. And in real life, I almost always try to avoid putting pins in because it seems to increase the stiffness, and the periosteum is strong enough to withstand. If you get a closed reduction, it'll most of the time stay in position. Do not put in transcapitellar pins. If they break, they're nearly impossible to get out, and they can destroy the joint. This is an example of a child who had this displaced radial head fracture that I was able to reduce and pop back on like a pop cap and stayed stable, so I did not put pins in. Olecranon fractures, I guess the biggest thing I'll tell you about olecranon fractures is that they're highly prevalent in kids with osteogenesis imperfecta. And it's also one of the sidebar ways that that's diagnosed. So if you see an olecranon fracture in your practice in an 8-year-old, if they fell right on their elbow, then that's probably not a big deal. But if it was a relatively simple injury, you might want to think in your mind about osteogenesis imperfecta. Just like in adults, the extension mechanism attaches to it. If it's displaced, it needs to be treated operatively for fixation. If it's minimally displaced, you can treat it in a cast. The treatment, the technique that I typically use in a very young child, I'll use tension band wire because of the apophysis of the olecranon. The downside on that we all know. It's prominent. It gets a bursa. You almost always have to go back and take it out. You can use screws if the child's older. I just don't like putting screws across an open apophysis if I can avoid it. Humerus fractures, almost always I treat these non-operatively. The only very rare exception would be if the child has a multiple extremity injury and needed it for mobility. Even that would be unusual because most of the time we can treat them in a splint. Even with this 100% displaced and shortened humerus fracture, the remodeling potential is humongous. They're able to heal the fracture, as you see on the left, and then 1 year later be nearly completely remodeled back to normal. Proximal humerus fractures, they will definitely ask you this question and try to pimp you as to how you would treat this as opposed to adults. In adults, a lot of times this will be treated with closed reduction and pinning. In kids, I'll show you an example right after this of an almost 90-degree angulated proximal humerus fracture on a child that's 8 that completely remodels. 80% of the growth of the humerus comes from the proximal humeral physis. It's the biggest discrepancy of any proximal to distal physis in the body. The knee is the second closest, with the femur being 70% distal and 30% proximal. So the remodeling potential is huge. There's the example, about 90 degrees of angulation at the time of healing. Here's a year later on the right-hand side. So the remodeling potential is enormous. Occiput C1 fractures, they're often fatal, so you don't usually get the luxury of taking care of these folks. In kids, they have a little more resiliency in their spinal cord, so they're able to withstand the stretch a little bit more. If they survive, then obviously they have instability and fusion. Occiput to the upper cervical spine is the treatment of choice, as was done in this child from occiput to C2. Odontoid fractures, in general, are treated in halos in kids. One thing I would tell you about a halo in a child as opposed to an adult is use more pins and less torque. In an adult, the common theme is to use 4 pins. In a child, almost always we use 8 at a minimum because of the sutures and you can't put as much torque on it or it will fracture through the skull. This is an example of an odontoid fracture type 2, probably through the synchondrosis. A closed reduction, I was able to obtain this reduction. I treated, that's the child you saw on the previous slide in the halo. Treated in a halo for 8 weeks until the fracture healed. Thoracolumbar spine, compression fractures. Once they're diagnosed, I treat these based on the symptoms and the location. Most of the time in the lumbar spine, if it's a significant compression fracture, I'll use some form of a corset or a brace. In the thoracic spine, I rarely use any form of brace. It's an intrinsically stable area, and I usually do not brace them. And also, most of the time, the children have compression fractures in the thoracic spine, have other associated issues with their breathing, and I do not want to put a brace on them to begin with. And so I treat most of those ambulatory without brace treatment. Unstable fractures, like any other unstable spine fracture or unstable spine segment, have to be stabilized. If you have a fracture dislocation such as this, certainly operative fixation or stabilization is the treatment of choice. Unfortunately, the majority of them have catastrophic neurologic injuries. Pelvis fractures, this slide I have one intentionally because it basically becomes an anatomic question. They'll want you to know what muscle attaches to that piece of bone that caused the avulsion from the lesser trochanter. They'll show here off the ischium if they want you to know that the hamstring avulsed. They'll show one here at the anterior inferior iliac spine or the anterior superior iliac spine. Typically the psoas, the rectus, and the sartorius occur from something on the order of a soccer kicker that kicks and misses the ball, or the other guy kicks it and he's unable to walk and presents to your office with hip pain. And that's typically how they'll ask it. The treatment for this is the treatment for those injuries is by and large crutch ambulation and activity modification until it heals, which is usually about 8 weeks. I've never operated on one of those acutely. There are very rare episodes where it can be operative, but never on a test. Hip fractures, it depends on where it's located in the hip as far as complications are concerned. The closer the fracture is to the hip joint, the higher the risk of avascular necrosis. Transepiphyseal fracture, which is essentially an acute slip capital femoral epiphysis, the AVN rate is about 100%. It goes down about 25% as you go distal to neck fractures, to peritrochanteric fractures, to intertrochanteric fractures, as far as the rate of avascular necrosis is concerned. Transepiphyseal fractures, the treatment is reduction and pinning the fracture in an improved position. Leave the pins a bit proud from a technical standpoint because you're probably going to have to come back and back them out when avascular necrosis sets in. Transcervical fractures, about 75% risk of avascular necrosis. Treatment is very similar to how it would be in an adult as far as what you do a reduction in pinning. The biggest difference would be where do you put your pins and where do you stop your pins. In this instance, I stopped the threads short of the physis. In this child that I believe is 8 years of age, I would not stop shy of the physis if I felt it compromised my fixation. I can deal with a limb length discrepancy a lot more readily and easily than I can a non-union or a femoral neck fracture that goes on to avascular necrosis. I'd rather have none of those, obviously. But if I can get enough threads across the fracture to create a stable fracture, then I will not go across the physis. But if there's any question at all, or if the kid's over 12, I just go across the physis to get the fixation if that's what you have to do to get a stable fracture pattern. Peritrochanteric or cervical trochanteric fractures, about 50% AVN rate in kids. If it's non-displaced, you can just treat it in a cast. If it's displaced, then typically we'll treat it with pinning, just as we would in an adult. In intertrochanteric fractures, almost always they're displaced. If they happen to be non-displaced and stable, then they can be treated in a cast. But the majority of them are unstable, such as this, and are typically treated either with some type of plate and screw device, such as you would in an adult. The real reason that we treat these femoral neck fractures is to avoid the dreaded complications. The complication rate is extremely high. Avascular necrosis, I mentioned previously. Femoral neck non-union is definitely an option as well. This child had treatment, I think it was in Canada, I'm not sure, but it doesn't matter where it was treated, and went on to a non-union after the screws were removed. The screws were removed because it was felt that the screws were part of the problem, and the child went on to a non-union. The treatment that they'll ask you on the test is, what's your treatment option for this? Well, one thing you want to do is this fracture line is more vertically oriented. From a biomechanical perspective, that puts it at a non-conducive to healing position. So if you do a valgus osteotomy, you can make that fracture pattern be more horizontally oriented, and through the biomechanical stresses, hopefully get some more compressive forces across the fracture or the non-union site and institute a union. So in this instance, proximal femoral or femoral neck non-union, the treatment answer is open reduction, internal fixation with valgus-producing osteotomy. Hip dislocations of the traumatic variety. Most of the time in kids we can do a closed reduction, and always after I do a closed reduction I get a CAT scan to assess the fracture stability, the congruency of the hip, and make sure there's no intra-articular debris. If it's stable with no intra-articular debris, then a spica cast is applied. I know that probably sounds crazy compared to the adult treatment options. I'm sure you wouldn't put an adult in a spica. But if you have a child like this who's 5 years of age and can't understand not crossing his legs, you put him in a spica cast for about a month, let the capsule try to regenerate itself. And long term, they do not have problems with stiffness. So it's a luxury that we have because they don't have the stiffness issues. Femur fractures is ever controversial. I'll try to go over what I feel is relatively not as controversial and therefore more testable in regards to femur fractures. We all have our pet peeves. That's how we treat it. From a testing standpoint, if the child is 2 years old or younger, the treatment is spica cast, without a doubt. No operative treatment on children less than 2 years of age. 2 to 5, spica cast is still the gold standard, but on a test, they'll have to show you how much shortening they have, how much angulation they have, and overriding, or tell you. So if it's greater than 2 centimeters of shortening in a child that's between 2 and 5 years of age, then you have these 3 options. You can do traction to try to get it back out to length and leave it in traction until the bone gets sticky or partially healed and then go to a spica cast. You can do an open reduction internal fixation procedure of your choice, plate, screws, rods, whatever, or you can do flexible nails depending on the fracture pattern. This child was treated with traction followed by a cast, and as you can see with the remodeling potential, this is 6 months later and this is a year and a half later. Traction in bed, then the child has a head injury as well. As you can see, we usually do 90-90 traction until you see the fracture starting to show some signs of fracture callus, usually palpable in the thigh. In a 7-year-old like this, that's typically 2 or 3 weeks in the hospital of traction. So obviously that has some socioeconomic issues associated with it. And then once you see the fracture starting to fill in with some callus, you can transfer the child over to a spica cast. 5 years of age up to skeletal maturity, we have lots of options available. You can use external fixation, flexible nails, open reduction, intramedullary nails, ream nails. Those are all available options. I think what you need to know from a testing standpoint is what are the downsides, what are the complications of each of those, and what are the specific indications accordingly. For example, with reamed intramedullary nails, it's very well documented now that avascular necrosis is the main issue. So on a test, the way they've been asking is if you're going to use an intramedullary nail device, the ream variety, where's your starting point? Piriformis fossa, no. Trochanteric starting point to try to avoid the avascular necrosis is the answer in that regard. In transverse diaphyseal fractures, one of my favorite operations is retrograde flexible nails. It doesn't matter what variety of nail you use, if it's stainless steel or titanium or what brand. They're inexpensive, and with the transverse fracture, they will interdigitate like you see here. I rarely even cast these kids. If it's a transverse fracture and they interdigitate, I usually do not cast them. Sometimes I'll put them in a knee immobilizer. They can be ambulatory and they heal rapidly. 6 to 8 weeks, they're healed. Fractures that are length unstable is the real issue. You don't want to, what we know for sure is you don't want to put flexible nails in a length unstable fracture. That's a recipe for shortening, angulation, complications, and a road you don't want to take. So if you have a length unstable fracture, which is would have to be described to you some way, or show you a picture such as this that has a large medial butterfly or segmental fragment. I think if you have a length unstable fracture, you basically have these 3 options. Well, I would add one more if you wanted to put the kid in traction, but in a teenager, that's not usually one of the answers they ask you on the test. You can do an external fixator, such as you see in this picture. You can do an open reduction and plating, or intramedullary nailing, or you can do a submuscular plating. Submuscular plating has come more into vogue over the past 2 to 3 years, and it's what we're using a lot here at the Denver Children's Hospital for sure. This is an example of a length unstable fracture with a segmental fragment. And I believe this child was 10. And so the options were those that we saw above. So we used submuscular plating, where there's basically semi-percutaneous plating, about a 1.5-inch incision distally and proximally, and then you put screws in at strategic points to attach the plate to the lateral aspect of the bone. We use a narrow 4.5 millimeter dynamic compression plate, and then you have a stable situation, which we do not use cast for. Reamed nails, from a testing standpoint, if you're going to answer the ream nail on the test, you better make sure that they either mentioned AVN or that you have to have a trochanteric starting point if there's an open physis. If there's no open physis, then treat it like an adult, like you would any other femur fracture. But the open physis is the key to that answer. Distal femoral physeal injuries, they're much more common than ligamentous injuries. If someone has a valgus stress to their knee and they have pain at their knee, medial collateral ligament injury is less common than a physeal injury. So do stress radiographs. See, obviously, if you have an x-ray like this, you don't need to do a stress radiograph. But in general, if the physis looks a bit wider, the tender over the physis, a stress radiograph may give you good information in that regard. The biggest problem with this injury is that it has a very high incidence of physeal arrest at the distal femur. That physis is very undulated, and any injury through that physis that creates this much disruption certainly can cause a physeal arrest or physeal shutdown. So closed reduction and casting is typically the treatment. Occasionally I'll put pins in if it's not stable. Open reduction if there's physeal, if the physis won't line back up, typically that means there's periosteum infolded in the fracture site. Intercondylar eminence fractures are commonly associated with a meniscal injury where the meniscus can be entrapped within the joint or within the fracture fragment. It's usually the anterior horn of the medial meniscus. If it's minimally displaced, you can treat it in a long leg cast. If it's hinged, commonly you can instill local anesthetic into the joint, extend the knee and get it to reduce. If it's completely displaced, you nearly always have to open it up either arthroscopically or if you're not arthroscopically inclined, you can do it via a little mini open technique to put fixation across the fracture site. This is an example of one that, as you can see, with a lateral radiograph that's hinged with significant displacement. Tibial tubercle fractures, much like the olecranon fracture in the upper extremity, the extensor mechanism is attached to the fracture fragment. If it's displaced, it needs to be treated with open reduction to restore the extensor mechanism. If it's non-displaced, a long leg cast and extension will be adequate. This is an example of one that was displaced, proximally migrated, as you can see, and a screw was utilized for fixation. This physis is extremely sensitive and almost always shuts down when this fracture happens. Patella fractures in children typically occur in the form of a sleeve fracture, as we call it. What I mean by that is just you see the sleeve of cartilage from the distal pole or the proximal pole. With this little tiny area here is the only area that's ossified. So on the x-ray, all you'll see is that the patella is in a superiorly migrated position if it's an inferior pole fracture, or the opposite if it's a superior pole fracture. And all you'll see is this little ossification to it. You have to look very critically to see it. On the test they'll say this child presented with this x-ray and has difficulty obtaining knee extension or something that bright, and you can see just this tiny little fleck of bone, and that the patella is abnormally tilted and inferiorly luxated. Here's an example of the other end, happened at the inferior pole. That needs to be treated operatively. Typically, you'll use a tension band wire type technique to get the patella or the extension mechanism back intact. Tibia fractures, toddler's fractures almost always are treated in a cast. Those will typically be asked on a test. It'll be a toddler age group, 18 to 2 years of age, who's refusing to bear weight on his lower extremity. That automatically, in my clinic, narrows it down to one of two things typically. Is it osteomyelitis or is it an injury? And so you have to kind of discern between those two. On the test, it almost always is easily discerned because they have to tell you one or the other. Classically, you'll see a tiny little crack in the tibia about the metaphyseal-diaphyseal junction. The treatment's easy. Just put them in a short leg cast. We never operate on those, and they always heal. Diaphyseal fractures in kids, almost always we treat those non-operatively unless it's multi-trauma or markedly displaced. If it's markedly displaced or multi-trauma, then we'll use intramedullary nails, but that's quite unusual. Proximal tibia fractures, especially the proximal tibial physis, the trifurcation of the arterial supply of the lower limb is right at the same level as physis. So you need to be very aware of that and ensure that there's not a vascular injury to the limb. If it's displaced, you treat it with closed reduction, and most commonly I will pin those because of the location of the vascular supply. I want to make sure that I don't have any further slippage or compromise to the vascularity at all. Metaphyseal fractures of the proximal tibia, the biggest thing you need to know about that is that it's prone to post-traumatic genivalgum. Almost always it's a fracture like you see here, just a tiny little crack, minimally displaced proximal tibia. And the main reason you need to know is for family counseling. When they come in, you tell them that we're going to try to mold this cast into a little bit of varus, and that there's a high chance that this child will grow into valgus deformity after the cast is removed and the fracture is healed. The reason we think that happens is if the tibia is fractured and the fibula is not, it creates a little bit more medial overgrowth along the line. It's usually self-correcting. Rarely do we have to do any osteotomies, and I dread doing osteotomies on these because if the post-traumatic genivalgum occurred from a minimal fracture, how am I going to keep it from happening when I do an osteotomy through the same area? And so most commonly they'll resolve spontaneously. It may take several years, and that's why it's on the test. Distal ankle fractures, this is an x-ray taken actually very similar to one that was on the exam. Markedly displaced distal tibia fracture, Salter-Harris 2 variety. In an adult, that would be an operative treatment most likely. In a child, closed reduction and casts, and there's the reduction. On the right, you see post-healing, no physeal arrest, and a neutral alignment at the ankle. Medial malleolus fractures, If they're displaced, they're intra-articular, they need to be fixed. I would say 90% of the Salter-Harris 3 fractures of the medial malleolus I treat operatively. The thing that I do differently and that I would if they didn't have an open physis is I use transepiphyseal fixation, and they have asked you that. This particular one is not a great example, but I can demonstrate for you. There's a distal tibial physis that's almost closed in this instance, but if this child was 8 or 9, let's say, the distal tibial physis is wide open. Normally, I would reduce this fracture and put my screws transversely oriented or horizontal to the tibial plafond within the epiphysis so that I do not cross the physis with my fixation. Teloe fractures occur from an external rotation mechanism of injury. It happens in kids that are nearing the end of their growth. The distal tibial physis closes first central, then medial, and last lateral. So this injury occurs right before they're done growing. They have an external rotation mechanism of injury. If it's displaced, it's intra-articular, so we treat it operatively and restore joint alignment. Triplane fractures typically look like a Salter 3 or a Salter 4 on the AP x-ray. And on the lateral x-ray, you'll see it coming up as a Salter 2 type variant from the distal tibia. Once again, if they're non-displaced, you can treat them non-operatively. If they are displaced more than 2 millimeters, like any other intra-articular injury, it needs to be treated operatively. You can see on the lateral x-ray how they typically have this Salter-Harris 2 fragment posteriorly. Pediatric upper extremity. This is one of the shorter ones comparable to the infection. I know you have some other hand talks earlier, so I'll go over the ones that are relevant, I think, to the pediatric section. Sprengel's deformity is something you need to recognize. Lack of descension of the scapula. It's associated with Klippel-Feil cervical spine anomalies, as well as congenital scoliosis and other upper extremity anomalies. This is a typical appearance. In my practice, I see this commonly. Children refer for scoliosis with the thought being that this is some type of rotational deformity in the spine. In reality, what it is that this scapula is twice the size of this scapula. So you need to recognize that that's what it looks like. It's a high, smaller scapula. The scapula starts proximal in the embryo and then descends throughout embryonic development down to its normal position. The treatment, by and large, is observation, but you need to know what a Woodward procedure is because they have asked that question. So a Woodward procedure is treatment of this deformity, and what you do is you try to pull the scapula down. So you have to detach the rhomboids and the periscapular musculature, pull the scapula down distally, usually attach it with some form of fixation to the spinous processes. So that's what a Woodward procedure is. In reality, it's not done very commonly, but they have asked it 1 or 2 times in the past. Congenital pseudoarthrosis of the clavicle has a clinical appearance of this on the right, radiographic appearance on the left. It's always on the right side, with one exception, if they have situs inversus. If they don't have situs inversus, it's on the right side every time. It's felt that part of the cause of this may well be some of the innominate artery and vein issues during the embryologic development. So much so that that's an honest answer. It's never on the left unless there's situs inversus. It's failure of fusion of the medial and lateral analoga or primary ossification centers of the clavicle. The treatment is either observation or surgery. There's no in between. If it's causing functional problems or deformity issues, the treatment is resection of the non-union and graft placement and fixation. It's fairly reproducible to lead to union. This is this child preoperatively, postoperatively, and then I have a follow-up radiograph showing the united clavicle. Congenital dislocation of the radial head is almost always posterior and usually combined with some form of bowing and shortening of the radius. The reason this is important is very testable. They'll show you this x-ray and say, do you think this is traumatic, congenital, developmental, etc.? This is a typical posterior congenital dislocation of the radial head. The head is usually larger or mushroom-shaped, and you have the bow that's typically present with a congenital anomaly as opposed to traumatic injury. The treatment for that is almost always observation. At skeletal maturity, radial head resection becomes an option. It's been well noted that the resection of the radial head does not improve the deformity, but does help with some of the range of motion at the elbow and hopefully eliminate some of the pain if they have issues with pain. Radial ulnar synostosis is a recognition phenomenon. You can see the x-ray that I have my arrow pointing to. The radius and ulna form in a mesenchymal stage as one onlog, and then from distal to proximal divide into two separate bones. So radial ulnar synostosis can be either the entire onlog in one piece or anywhere from proximal to distal. So this one is one that almost split, or almost completed its split, but didn't quite the proximal 1/3. So almost always they're proximal third or proximal half, and that's the reason why. Usually, obviously they don't have forearm pronation and supination. The treatment for this is dependent on function. The major lack of function is if they have both arms and they're both locked in pronation or supination. If that's the case, then from a functional standpoint, osteotomies can be performed to try to get one arm into pronation or mid-pronation and the other one into supination for functional purposes. You cannot go in and resect the onlog and create a radius and ulna that's normal. It'll re-ossify. You can see how closely and intimately those are associated. If you go in and try to resect that, it'll rapidly recur. So osteotomy and repositioning is basically the answer. Madelung's deformity is a form of a dyschondrosis of the distal radius, similar to Blount's disease, which we'll talk about in the last section about the proximal tibia. It's radial and volar displacement of the hand due to a partial deficiency of growth of the lateral aspect of the distal radius. This is always asked when it's asked, it's always asked as to whether or not this is congenital, developmental, or traumatic in nature, and it's congenital in nature. It's a dyschondrosis. Most of them are asymptomatic. With this child that didn't have any symptoms at all, came in to see me for this deformity. If the deformity does become an issue or they start to have pain, then an osteotomy to try to restore the mechanics of the distal radius is the most appropriate treatment. Congenital amputations in the upper extremity, as I mentioned previously, based on their developmental status, we try to fit them into upper extremity prostheses at or about 6 months of age, because that's when they start to sit and use their hands in a supported fashion. As you can see from this child, the initial prosthesis is almost always a passive mitt at about 6 months of age. Radial club hand is a recognition deformity. As you can see, this child it's a longitudinal deficiency of the radius, much like longitudinal deficiency of the tibia, fibula, and femur that we'll talk about more. Probably related also to the sonic hedgehog gene, although it's not been specifically implicated in radial club hand yet. Their whole radial side is commonly absent, including the thumb or various parts of it. They can be missing the entire thumb and radius or any parts of it. It's not very common, about 1 in 100,000 births. TAR syndrome, thrombocytopenia absent radius, is one syndrome associated with it, as well as Vachteral or Vater syndrome. The treatment for this is 100% dependent on the elbow. If you have an elbow that does not move, or you have no biceps function, it makes no sense to push the radius out to the distal aspect of the arm. If they have no biceps function, they will not be able to get their hand to their mouth if you centralize the radius. So biceps function is crucial to decision making as far as whether or not to centralize the radial club hand. One interesting side note is with thrombocytopenia absent radius, they typically have a thumb. And I can't believe it, but they actually asked that question 2 years ago. They showed this very similar radiograph to this and said, what do you think the diagnosis is? And you had to know that it was TAR because the thumb's present in a radial club hand. Duplicate thumb, I'm sure you've heard about this in your previous talks on the hand. The treatment is based on function. Almost always these end up being resected. Typically we'll take the lesser or non-dominant remaining digit and leave the thumb intact. We try to, with the thumb being a pinch mechanism, you want to try to either leave the medial collateral structures or you have to reconstruct them if the medial structure is the one you have to remove. The syndrome section is the section that's probably the most heavily modified on an annual basis. Not because I'm passionate about syndromes, but because as they learn more about them, they continue to ask more questions. Specifically, they can ask questions relative to gene locus and gene therapy, and which is a very hot topic as far as molecular genetics is concerned. The common things that all syndromes and dysplasias have, especially the ones related to the orthopedic issues, is that they're typically short in stature. They have bone deformities, somewhat of a peculiar appearance, and they're familial in nature, hence the molecular genetics angle. A skeletal survey is almost always classic on the OIT. What I mean by that is they don't show you a fuzzy case of, of some unusual dysplasia. They'll show you a classic case from a skeletal survey standpoint. And it's then up to you whether or not you recognize that dysplasia or not. Chromosome analysis has become, and gene mapping are at the forefront now in the molecular genetics field. Histologic studies and biochemical assays are also very helpful, and I'll go over a few salient features of those. The basics of it are, and I'm not trying to bore you to death, but the bottom line is with these, if you understand the next about 10 slides, if you're willing to bear with me, it kind of helps me, at least in my mind, stratify these and understand how it can make some sense. The human body is divided into those basic three. You have cells, extracellular substance, and body fluids, which then the three primitive germ cell layers, ectoderm, endoderm, and mesoderm, give rise to your four primary adult tissues: epithelium, muscle, nerve tissue, and connective tissue. The connective tissue is composed of bone, cartilage, and fibrous tissue, and each of these tissues has characteristic cells and substances associated with it. The bone has the osteoblast making osteoid, cartilage, chondroblast making chondroid, and fibrous tissue with the fibroblast making collagen. The extracellular substances about these tissues are mainly in the form of collagen fibers, whether it's type 1 for bone, or type 2 for cartilage, or reticulin and elastin fibers. The main hallmark being that these are all held together by a ground substance composed of proteoglycan. I used to hate this slide because I could never figure out what all these little fibers were. But the bottom line is, if you look at the names of the issues associated with this, they're very prevalent now that they've delineated what causes some of these mucopolysaccharidosis, for example, with keratin sulfate chains. There's a very distinct protein core with chondroitin sulfate and chains associated with that, and hyaluronic binding acids. These all are critical in delineating which type of mucopolysaccharidosis, for example, the child may have. At 4 weeks in the intrauterine life, and this is what we've talked about earlier with our limb deficiencies, you're starting to just begin limb bud phase. And that's when the sonic hedgehog gene comes into play, as well as the Hox gene. The Hox gene and sonic hedgehog gene basically stimulate the limb bud formation. And this has been on the test, it was on the boards last year for sure, about what gene is responsible for inducing limb bud formation. And the Hox gene and the sonic hedgehog gene are the two genes, and it occurs in about 4 to 6 week old embryo, which is pretty fascinating if you think about it. At 8 weeks, the skeleton starts to form cleavages within the joints, within the cartilaginous onlog. And that's important because then you start to develop the primary centers of ossification. We talked about that earlier with the clavicle pseudoarthrosis, for example, being an area where the two centers of ossification did not cleave together, did not form together. Secondary centers of ossification, such as the epiphysis, then start to form subsequently. And the physis is a very stratified and very organized columnar-shaped cartilage matrix with the hypercellular area right next to or adjacent to the zone of provisional calcification. So there's two ways the body can form bone: intramembranous and enchondral, excuse me. The groove of Ranvier is crucial right at the ridge, at the lateralmost border of the physis. This helps in forming the metaphyseal cutback and in the modeling of the diaphysis and metaphyseal areas of the bone. And these are all important. I know right now probably you think I'm going off on a tangent, but there's epiphyseal dysplasias, there's metaphyseal dysplasias, there's diaphyseal dysplasias, and they all have specific focuses, and they're all related to these previous 10 slides. And that's what I'm going to go into here now in the next couple sections. So the molecular genetics is extremely hot as far as testing is concerned. I think probably the number one code word would be fibroblast growth factors. They're very important for cell induction, differentiation, and migration. And they're also extremely important in bone growth, angiogenesis, and wound healing. There are many of them that have been identified. FGFR3 is the one that they've been asking largely. It affects skull and long bone development. And as you'll see on multiple slides coming up, if you think about it, what would be the most likely skeletal disorder to have skull and long bone development? And that's achondroplasia. They have frontal bossing, large skull, relative, and short limbs. And so FGFR3 is the predominant identifying characteristic in achondroplasia. Also, it's coded for on chromosome 4, the short arm of chromosome 4. which they haven't asked that yet, but it's probably up and coming since it's now been localized. Hypochondroplasia is just a lesser severe version, and thanatotropic dysplasia they don't typically have the skull deformities. So abnormalities that affect the formation of the cartilagous homolog or the primary ossification center are things we talked about earlier: proximal femoral deficiency, where the entire proximal femur or any their portion thereof it can be missing. Cleidocranial dysostosis, where the clavicle can be absent. And Apert syndrome. I'll show you examples of those three. This is a child with femoral deficiency, which we've talked about previously. The entire portion of the proximal femur is missing. Shortened and external limb. This is a child as an infant, and this is the same child now 10 years later. The deficiency can be as much as up to 25 centimeters if the whole femur is missing. Cleidocranial dysplasia, their dysostosis, they do not have the clavicles form, and so they're able to have unbelievable motion about the shoulders. As you can see, it is definitely familial, and as you can see, chromosome 6p has been delineated. Apert syndrome, I show you just so you know, is a recognition deformity. The child, because of the FGFR gene, the skull has multiple abnormalities, and they have a very abnormal or dysmorphic-looking face. They have very complex syndactyles, what's called rosebud hands, where the fingers are all melded in. This is a hand in the center here, and this is the radiograph of the same hand. So they have lack of delineation of the fingers, all because of the chromosomal anomalies. The secondary centers of ossification, if you look where the arrow is pointed, the secondary centers are always in the epiphysis. So it makes sense then, at least to me a little bit, that then on the right-hand side of the slide, all the epiphyseal dysplasias are listed, because the defects that occur in the secondary centers of ossification involve multiple epiphyseal dysplasia, spondyloepiphyseal dysplasia, and diastrophic dysplasia. Those are autosomal characteristics. The more severe the diastrophic and the SED tarda are autosomal recessive, but they all come from a primary, their major problem is the secondary center of ossification. MED, or multiple epiphyseal dysplasia, comes from an abnormality on chromosome number 19, which fails to code for the COMP gene, and then they have a decrease in type 2 collagen. I've seen all three of those things mentioned on the test in the recent, most prevalently being that you have to know that it's type 2 collagen, it's a deficiency. That makes sense. It's an epiphyseal dysplasia, so it's a type 2 collagen. They have joint incongruity, which leads to early adulthood arthritis. Commonly, these folks need arthroplasties early on in life. The spine is normal. The big thing to remember about multiple epiphyseal dysplasia is the hips look very similar to Perthes disease. Remember earlier when I showed you the child with Perthes disease, and they have the coxa magna, coxa breva, and subluxation? The thing that typifies multiple epiphyseal dysplasia is that it's bilateral, and it's symmetrically bilateral typically. Perthes disease can be bilateral about 12% of the time, but it's never bilateral simultaneously in the same stages. One side will heal, and then they'll get Perthes on the other side later on. SED, or spondyloepiphyseal dysplasia, comes from mutation on chromosome 12, and once again it's type 2 collagen because it's epiphyseal. They typically have flattened or platyspondyly, most evident in the lumbar spine. So if you see a child with multiple epiphyseal dysplasia on the test and they don't show you a spine x-ray, and that's what they're looking for, the next test is going to be to order x-ray of the spine to make sure that it's not spondyloepiphyseal dysplasia, both of which would be type 2 collagen deficits, but multiple epiphyseal dysplasia does not involve the spine. In all of these instances, you need to be careful. The cervical spine in particular, with any of the dysplasias in the long bones, they can have upper cervical spine instability like we talked about earlier in the spine section. Diastrophic dysplasia comes from chromosome 5 mutation, which codes for a transporter protein, and they have the proteoglycan string that looks like the fuzz is underdeveloped and undersulfated, and therefore isn't able to carry the protein as well. And that leads to problems with the development in the extremities in particular. The diastrophic dwarf the code word is called a twisted dwarf. They're very short, typically the adult height is about 42 inches. Very stiff club feet, bad scoliosis, hip dislocations. They also have hitchhiker thumbs. These are code words that they like to tell you that you need to know that that's what they're talking about. Cauliflower ears. Those are typical stigmata of diastrophic dwarfism. They also can have severe cervical kyphosis, which can be paralyzing. So if you see a child with diastrophic dwarfism, once again, you need to make sure they don't have cervical kyphosis. So now you move a little bit distal to the physis, and hopefully this is helping as far as tying these together. If it's not, just let me know and I'll change accordingly. The physis affects, obviously, from multiple issues. Achondroplasia probably being the most prevalent, having an abnormal physis, mucopolysaccharidoses, and enchondromas. The abnormal chromosome 4p, as we previously mentioned, codes for fibroblast growth factor number 3. The pathophysiologist is that the chondroblasts then are not able to reproduce and form that columnar shape that's typically at the physis in a normal child, and therefore can't produce the normal amount of chondroid. This leads to, as you would imagine, if your physis is not functioning well, to dwarfism, where your legs and your arms are shorter. Typically it's rhizomelic in nature, meaning rhizo meaning root, meaning the proximal segments, like the humerus, are shorter relatively than the forearm, and the femur shorter relatively than the tibia. Frontal bossing occurs because that FGFR codes for the skull development as well. Bowed legs, and their adult height is usually about 50 inches. Normal adult height of about 48 inches for an achondroplast. As I previously mentioned, it's a rhizomelic form of dwarfism, meaning that the proximal segments are more shortened than the distal segments. One thing you need to know particular about achondroplasia, in addition, is they also commonly have spinal stenosis. Just like their limbs are shortened, their pedicles are shortened. So if you have short pedicles in your spine, that leads to a very cramped area for your thecal sac to live in, and so it's a congenital form of spinal stenosis. The mucopolysaccharidoses are basically, in a nutshell, a group where they have their inability to metabolize one or several of the proteoglycan strands that we talked about earlier in this talk. The tissue affinity depends on what the proteoglycans left, whether it's keratin sulfate, heparin sulfate, etc., depending on where it's going to deposit in the brain, the liver, etc. Hurler's syndrome is an autosomal recessive. The deficiency is alpha L ironidase, and therefore it's not able to metabolize. The dermatin sulfate is what accumulates, and it typically accumulates in the central nervous system. Currently, especially I believe it's at Duke University, they're utilizing bone marrow transplants fairly successfully, an enzyme replacement to try to alleviate this. Formerly this was a lethal syndrome. Hopefully we're going to make some strides, and that's some of the benefits of the molecular genetics. Sanfilippo syndrome is heparin sulfate is the accumulating protein, and it's autosomal recessive as well. Morquios, keratin sulfate. And morquios, they typically have genu valgum, as you can see this smiling youngster on the left-hand side, but classically shortened in stature because it affects the cartilage at the growth plate, and the keratin sulfate accumulates. Once again, I put this in there again intentionally. Remember the cervical spine and all these mucopolysaccharidoses. If they're going to have surgery for that genu valgum that we just mentioned, make sure their cervical spine is stable. So on the test, make sure they have cervical spine flexion extension radiographs to assess the stability of the upper cervical spine. Enchondromas can also affect and are a direct effect of the cartilage cells of the chondrocytes. Solitary is one option or available option. Multiple can occur, and that's called Olliers disease. If they have multiple enchondromas and the hemangiomas, that gets categorized as Maffucci's. Enchondromas pathophysiologically, basically chondroblasts escape the normal physis in that center and are able to then grow in the metaphysis of the bone, such as this being a large section of chondrocytes within the metaphysis. What that can accomplish then is it can create a tethering effect, for example, in this child at the medial aspect of the distal femur or lateral aspect of the distal femur. And with that tethering effect, with normal growth on the medial side, create a valgus deformity depending on the side of the bone that's involved, valgus or varus. It also can create shortening if it's centrally located and tethering the physis in that manner. Malignant degeneration into chondrosarcoma is quite rare in solitary lesions. About 10% of the time occurs in Olliers and about 60% of the time in Maffucci's. But the biggest thing to remember is with Olliers is that they have a very high rate of skeletal and non-skeletal malignancies. The groove of Ranvier, defects that infect the groove of Ranvier can create an osteochondroma. The body's trying to form an extra limb, if you think about it, or an extra bone. Dysplasia epiphysealis hemimelica, or Trevor's disease, is another example. This is dysplasia epiphysealis of hemimelica, which is Trevor's disease, is essentially an osteochondroma that occurs in the epiphysis. So rather than growing up out of the metaphysis, it grows in the epiphysis, markedly enlarges, in this example, the medial femoral condyle or the distal femur. It's a benign cartilage lesion. Typically, the osteochondromas are either sessile or pedunculated and completely benign in nature. The treatment is either observation or surgical excision. The chances of malignant degeneration are very small. The osteochondroma is basically a defect in the EXT gene, which has just come out recently as well. And as it would make sense somewhat, since the body is essentially trying to grow an extra limb at the node of Ranvier, the Indian hedgehog gene has been implicated as a potential option and is being investigated currently. So at the physis level, you can also have anomalies associated with the mineralization of the physis. That would be in the form of rickets. Now, obviously, that's going to be at the zone of provisional calcification. So we're moving down in the physis now. Vitamin D dependent, vitamin D resistant, renal rickets, and GI rickets are all, or nutritional rickets are all possible options. The pathophysiology is basically that they're unable to mineralize the chondroid. The chondroid's forming, but it's unable to be mineralized. So therefore, on the x-rays, what you're going to see is a widened physis. The zone of the physis is going to be wider because there's no significant calcification going on within the zone of provisional calcification. Vitamin D resistance rickets is a familial-based sex-linked dominant issue. Phosphate diabetes would be another way of describing it. Typically, they'll have bowing in their tibias and the lower extremities, as you see in this family, because the proximal tibia responds with that widened physis to a bowing stress. Typically, renal rickets is associated with secondary to renal failure. The kidney is not able to convert vitamin D, and therefore the calcification process is affected that way, and that affects the zone of provisional calcification in a similar manner. The secondary hyperparathyroidism causes many of the deformities that you see in the bone. As I mentioned previously on the SCFE section, if you have any kind of metabolic issue or the child's less than 10 or systemic problems, that bilateral pinning would be predominant and the correct answer. So then moving further down and on the lowest list of the at the physis is disorders affecting the production of osteoid. Osteogenesis imperfecta being number one, and scurvy, which is relatively rare now, but due to a vitamin C deficiency. So in OI, they're unable to make normal type 1 collagen, or at least not able to make it at normal rates. And so if they're not able to do that, then their bones become more fragile. They're not as biomechanically strong. About 90% of the OI patients will have a genetically determined defect in the production of type 1 collagen. The Sillens classification, which came out years ago, is now known to be, it's much more multifactorial than it was previously. The osteoblasts at the physis level are able to reproduce, but they can't form normal appearing osteoid, and that's the predominant problem. The osteoblasts in the periosteum are unable to provide adequate amounts of osteoid as well, and that creates a difficulty in remodeling as well. In mild cases, they'll have just a few fractures. In very severe cases, where they're totally unable to make adequate osteoid, they'll have fractures at birth and can even be fatal. In OI, the treatment now is leaning more medical, pamidronate being osteoclast agonist, so to speak, trying to diminish the amount of bone resorption, and that's helped diminish the fracture rate significantly. They commonly, after multiple fractures, will get a saber shin appearance in the tibia or bowing in the femur and the humerus and long bones. The treatment for this is either observation or if it's severe enough, we do multiple osteotomies, the so-called shish kebab or Sofil procedure, where you literally cut multiple osteotomies and then skewer, take out one section typically, and then skewer the bone into a better alignment, such as this. Same x-ray 4 years later. Scurvy comes from a vitamin C deficiency, and that prevents the conversion from proline to hydroxyproline. Microscopically, it's quite similar to OI in the osteoblast region. On the x-rays, they'll have this lucent line at the proximal aspect of the physis, which makes sense if you think about it. That's where the osteoblasts are, creating the osteoid. Abnormalities in normal remodeling are going to be more distally, sources of metaphyseal dysplasias, Gaucher's, osteopetrosis, and osteopetrosis in particular. Osteopetrosis is autosomal recessive, and this is very commonly asked on the board exam as well as on the in-training exam. See the sort of rugged Jersey spine, very dense bone in the femur as well as in the spine. It's a failure of the osteoclast to adequately remodel the fractures. You can see there's not much remodeling or shaping. The metaphyseal cutback zone is not working well here in the femur. You can see it has like a block-shaped femur about the distal femur. It's highly lethal if it's not treated because it eliminates the marrow. So the treatment is a bone marrow transplant. It's been mapped out to chromosome 11q now, that just came out in the last 2 years. Neurofibromin is the code gene for neurofibromatosis, coded for on chromosome 17. The classic physical stigmata of neurofibromatosis: cafe au lait spots, marked hemihypertrophy, scoliosis, as we previously talked in the spine section. And one thing I want to particularly mention is pseudarthrosis of the tibia. If you'll note, that's an anterior bow on the lateral radiograph and lateral bow on the AP. So anterior lateral bowing, that should ring a bell automatically, especially as compared to posterior medial bowing, which we'll talk about in the next talk. Anterolateral bowing in neurofibromatosis is almost always a precursor to congenital pseudarthrosis of the tibia. Pathognomonic for neurofibromatosis is a plexiform type neurofibroma. This is a visible example of what a plexiform neurofibroma looks like. Looks like a bag of worms once you open up the neurolema. Marfan syndrome, fibrillin is the protein coded for on chromosome 15q. The typical clinical stigmata is the arm span is greater than their height. They'll have superior lens dislocations, mitral valve prolapse, and marked ligamentous hyperlaxity. Commonly, they have scoliosis. The treatment of their scoliosis is quite difficult because of their heart issues with mitral valve prolapse, and they also have aortic issues. Arachnodactyly or spider-like phalanges, which are long and slender. Down syndrome, which I know I've talked about multiple times, but it's asked a lot on the test. Trisomy 21, one of the original chromosome anomalies to be noted. Generalized ligamentous hyperlaxity is definitely a hallmark. C1, C2 instability is definitely a hallmark. Treatment of the C1, C2 instability, if they're asymptomatic and they're less than 10 millimeters, no treatment at all, and they can participate in normal activities. If they're symptomatic and their ADI is greater than, or their ADI is greater than 10 millimeters, those are the children we treat surgically, and the surgical treatment is typically a posterior fusion. They commonly have patellofemoral instability as well. And it does not respond well to non-operative management, and typically you have to use the medial support structures like we talked about in the hip talk and the knee talk about using the semitendinosus as check-ring ligament medially. We're down to the last talk. I'm sure you can hardly wait. Let's see. So I'm sorry to bombard you with all that about the syndromes, but they've been asking more about that, and I'm sure that's going to continue. So at least I'll have a reference. I don't know, for me, if I don't look at it every once in a while, it just leaves my brain, but maybe your brain works different than mine. The last section is pediatric leg, foot, and ankle. Not as complicated as the previous talk, so hopefully this will be a little more enjoyable for you. Fibular hemimelia. I know we've talked about it a bunch, but it's a longitudinal deficiency. This is longitudinal deficiency of the fibula. So if you think about it, if your fibula is missing, your foot's going to drift into equinus and valgus because you have no lateral support. Once again, the Sodden's hedgehog gene rears its ugly head, but they have a limb length discrepancy associated with this as well. And this is a typical foot appearance for a child. They'll commonly be missing some of the lateral rays of the foot, as many as 2 or 3 or as little as 1. The treatment is 100% dependent on the foot, meaning if they have a good foot, meaning, by definition meaning it's a flat foot, such as this nice young lady with a plantigrade foot with 4 toes or more, that's a good foot that is salvageable. If they have a bad foot, if they have 1 foot, 1 toe, or 2 toes, and the foot's in marked equinovalgus, most likely they're going to be better served with an amputation and prosthetic conversion. From a test standpoint, that's for sure the answer. So on the test, if they have 4 rays or more and a good foot, it's worthy of limb salvage. If it's 2 or 1 ray of the foot and a markedly deformed foot, amputation or limb ablation and conversion to prosthetic wearing is the most appropriate. The time to do the amputation is likewise with our prosthetic answer. You want to do it at or about so they can get up and start walking at about a year of age. The biggest thing I could tell you about treating these kids is the charts. When I see these kids in follow-up, the children that have the bad foot, like you can see on this child on the right, has one operation in his whole life because I do a disarticulation, not a diaphyseal amputation. One operation. His chart's about an 1/8 inch thick with 5 pages in it. Comes back every other year to get his prosthesis renewed. The kids that have a lengthening have a chart that's like telephone books stacked up on top of each other because they come back for multiple operations repetitively over and over again. So at some point I look at that and wonder sometimes what decision I should make, and I have them talk to each other. I think that's the best way. So the other side of the leg, the tibial side or the medial side, can also have a longitudinal deficiency. As you would think common sense-wise, if the tibia is missing, there's no medial support, so it's going to go into equinus and varus. Looks a lot like a clubfoot. And when these kids come in to see in the clinic, they do look a lot like a clubfoot, and almost always that's what they're referred for, is for clubfoot treatment. But you look at it, and it doesn't feel like a clubfoot because it's more flexible than a clubfoot would be, and there's no tibia. You can feel that there's no tibia. It's autosomal dominant, and the only one that's known to have a delineated autosomal gene in that regard. It can happen in just like any of the other longitudinal deficiencies, whether it's the radius, the fibula, or the femur. The tibia also can be partially present, completely absent, or anywhere in between. And it can be, interestingly, in the tibia, it can be all 100% present but have a complete diastasis distally, such as the type 4s, which are exceedingly rare. The type 4 is about 1 in a million. The treatment, much like the fibular deficiency, depends on the foot deformity. The tibial hemimelia treatment depends on the quadricep. So if you have a proximal tibia with a quadricep attached, that means you have knee extension. So if you have knee extension, you should do everything you can to maintain that, because then they can be a below knee type prosthesis wearer. And so that's crucial. So that drives the treatment 100%. They commonly have bizarre toe anomalies, as you see of this child on the left. If they have no quadricep function, they're probably better off having a knee disarticulation, because you can't create a knee extension mechanism. So if they have complete absence of knee disarticulation, such as this, once again, that's the small chart. They come in because one time, then they come back every other year to get their prosthesis renewed. But outside of that, they're in good shape and they're ambulatory independently. If they have a partial deficiency, such as this child, with an intact extensor mechanism, trying to create a synostosis between the proximal tibia and fibula is a reasonable option. Another option is you can cut the fibula and put it on the distal aspect of that tibia and ablate the foot, and then they have a functional below-knee type prosthetic wearing capability, which is much improved from having an above-knee prosthesis. Congenital pseudoarthrosis of the tibia. Remember before in the neurofibromatosis section I talked about anterior lateral bowing. This is what it looks like clinically. Heavily associated with neurofibromatosis. Sometimes they don't fracture until after 5 years of age. They can be a late presentation. But the majority of them, especially with neurofibromatosis, present with a fracture in their first year of life. So anterior lateral bowing of the tibia, you need to think about congenital pseudoarthrosis of the tibia and recognize that it's associated heavily with neurofibromatosis. This is what the radiograph looks like, and commonly they'll show you this exact kind of radiograph with an anterior bow and a lateral bow on the tibia. See some diaphyseal changes within the tibia. It's almost always at the junction of the distal and middle thirds of the tibia. For an established congenital pseudoarthrosis of the tibia, or an established pseudoarthrosis, the treatment is typically an attempt to get a fusion to occur. Usually that entails some form of intramedullary nailing device. The reason we like the intramedullary nailing device is it provides ongoing support for a bone that's congenitally weakened and has inability to heal. And then some type of bone grafting, typically autograft iliac crest. Vascularized fibula is definitely a viable alternative. The hard part about the vascularized fibula is almost every time the fibula, as you can see on this image on the left-hand side of the screen, almost always the fibula is fairly gracile on the side of the congenital pseudoarthrosis of the tibia and not a good candidate for the vascularized transfer, so therefore you have to go to the other limb and operate on their good leg to remove their fibula to put it in place. Problems we see with the vascularized fibula are almost always it'll heal at one end or the other, but about 50% of the time you'll get a non-union at either the top or the bottom. So there's obviously something wrong with the entire tibia in these kids in these congenital pseudoarthrosis of the tibia. Intentionally, this is right after that, posterior medial bowing of the tibia. You can see the x-ray appearance and the foot. Obviously a very dramatic looking deformity about the foot in a brand new baby. Parents are always in great distress when they come in to see with this deformity. The foot looks like it's on backwards. They have an associated calcaneal valgus foot deformity. The comforting part about this is the posterior medial bow of the tibia will always remodel. It commonly takes 5 to 7 years to remodel the bow of the tibia. But from a testing standpoint, what you need to know is that they'll want you to know what's the ultimate outcome on a long-term basis, and the ultimate outcome is that they'll have a 2 to 5 centimeter limb length discrepancy at maturity. As you can see in this young lady, started off with this deformity and now has a 2.5 centimeter discrepancy at maturity. Blount's disease, we talked about earlier how it's similar to Madelung's at the wrist, a disc chondrosis about the medial and proximal aspect of the tibia. Infantile Blount's is a separate category. There's an adolescent type, which I'll talk about next. In infantile Blount's, it typically has its onset at about 3 years of age. They have varus knees or varus alignment of the lower extremities, and the Langenskold classification is what I have the picture of here. A Langenskold 1 is medial to metaphyseal beaking on up to a Langenskold 6, which there's a congenital bar across the medial aspect of the tibia. Obviously, if you have a congenital bar, you're going to have a markedly, progressively worsening deformity. In Langenskold 3s and less, where there's no bar and no step-off, you can see that's the big difference between a 3 and a 4. Bracing is an available option. The major thing you need to know from a testing standpoint is to make the diagnosis. The treatment is somewhat controversial, but to make the diagnosis is not. The metaphyseal diaphyseal angle of Drennan is what's quoted. The metaphyseal diaphyseal angle of Drennan, if it's greater than 13 degrees, is pathognomonic for Blount's disease. I have not seen them ever make you measure it. Obviously, they can't make you measure it because you can't bring any instruments into the test. So they'll have it drawn out, or they'll just tell you that the metaphyseal diaphyseal angle is greater than 13 degrees. If it's stage 1 through 4 and they don't have a bar or a step-off, brace treatment is one available option. The hard part is if it's bilateral, to try to get a child to wear bilateral braces, which have to be KAFOs. They have to go up on the thigh because they have to cross the knee joint. It's very difficult to get compliance to use. Unilateral cases, it's more susceptible to treatment with braces. If it's stage 5 or 6, obviously those have to be treated surgically because they have a bar across the physis. So you either have to try to resect the bar or do osteotomies to try to realign the limb. Typically both are done. The key with treatment of osteotomy treatment for Blount's disease and infantile Blount's is to overcorrect the tibia into excessive valgus. Because there's a bar there and the disc chondrosis, it's not going to grow normally along the medial physis. So the suggested amount is at least 10 to 15 degrees of valgus at the tibia at the conclusion of your osteotomy. Adolescent age group Blount's occurs typically in a similar population that you will see Skippies in that we talked about earlier today. Slightly overweight adolescent age group. The common treatment options are observation in less severe cases. Obviously in a young man with this amount of deformity, a lateral hemiepipsidesis is one option where you stop the growth on the lateral aspect of the proximal tibia, allow that slowing growth on the medial side to correct itself. Medial tibial osteotomy is an additional answer. This child had, as you can see, the stapling procedure in the lateral hemiepipsidesis, and over about 2 years was able to correct his deformity. Down to the foot, which is the last section. Club feet. Very typical appearance, as I previously mentioned, it looks somewhat similar to tibial hemiamelia, but you'll be able to palpate and feel the tibia. This is an idiopathic type clubfoot. The hind foot is an equinus and varus. The forefoot is supinated and an adductus, and the midfoot has cavus. Those are the classic 3 sections of deformity associated with a clubfoot. 100% of the time when I see a child with idiopathic club feet, and from 100% of the time on the testing, the initial treatment for club feet is serial manipulation and casting. The success rate for casting being 100% successful is about 50%. Long leg casts need to be utilized, and that's been proven out in the literature now over the past 3 years. Hindfoot parallelism is seen between the talus and the calcaneus on lateral radiographs. Surgery, if it's going to be performed from a soft tissue release standpoint, is typically done at about 9 to 10 months of age, so that they can be ambulatory at about a year of age. The Ponseti method has had a rekindling, which is out of Iowa, and the Ponseti method entails a very rigorous casting, followed by a surgical lengthening of the Achilles tendon in about 8 weeks. With that double combination, there's about a 90% chance of treating it with the tendo Achilles lengthening only and no formal open release. The hard part about the Ponseti treatment is you have to have strict compliance with bracing afterwards. These children are corrected at about 2 months, and they have to wear Dennis Brown bars and braces for the first 2 years of their life. Vertical talus, rocker bottom foot that you can see with the marked deformity. Always they'll show you the radiographs, and for some reason they put this on the test extremely commonly. You see a dorsal dislocation of the talonavicular joint. There's no navicular ossify in this young child, so you draw a line along the first metatarsal and it runs you directly into the dorsal surface of the navicular, whereas the navicular should be directly in line with the first metatarsal. It's often associated with syndromes, commonly associated with spina bifida. The X-ray diagnosis, which is what they'll test you on, they'll show you a plantar flexion lateral, which is what this X-ray is right here. The purpose of the plantar flexion lateral is to show you whether or not that talonavicular joint reduces itself. It's obviously dislocated here. Here's the first metatarsal a line going directly into the dorsal surface of the navicular. On the plantar flexion lateral radiograph, you're not able to reduce it. You can see they're parallel, but it's obviously dorsally dislocated. That is, by definition, a vertical talus. Casting is virtually never successful in reducing that. So surgical release is the treatment of choice, and it's usually done about 9 months of age to reduce the talonavicular joint, and classically will pin in the joint as you see in this radiograph. Calcaneal valgus is a positional deformity of the foot. They do not have the dorsal dislocation of the foot, and you get a plantar flexion radiograph and it will line up the first metatarsal with the navicular. Treatment for this same child with this deformity had passive manipulation by the family, and this is the child at a year of age with a normal looking foot. Metatarsus adductus treatment is dependent on the severity and the stiffness. When it's supple, such as this child, and you can correct it beyond the midline, stretching is all that is needed. Need to remember that like the other packaging deformities, like the torticollis, it's associated with developmental dislocation of the hip, about 15 to 20% incidence. The stiffer feet with a crease along the medial bore of the foot, such as this, and what I call an atavistic great toe, commonly need to be either casted or use some type of bracing to maintain a straight lateral border to the foot. Extremely rare to need to do surgical treatment for metatarsus adductus. This x-ray is on a child that had a severe clubfoot that had residual adductus that was treated surgically. I put it in there for demonstration purposes only. Almost never do we need to do that, but if you do, the Heyman procedure where you do multiple metatarsal osteotomies with forefoot pinning is still a reasonable thought process. Bunions, a beloved question on the tests, adolescent bunions in particular. The main reason they're on the test is that they have a heavily prevalent recurrence rate, especially if the physes are open. This is a demonstration of what is a good example of treatment. Try to have them wear wider shoes as a normal form of treatment. They tend to outgrow the early operation, which is extremely frustrating. That is probably the #1 complication in treating adolescent bunions. So if you're going to treat it surgically, wait until the physes are closed. And you almost always have to include a metatarsal osteotomy because metatarsus primus varus is usually the predominant deformity. Cavus feet. If you see a cavus foot earlier, we talked about Charcot-Marie tooth and Friedreich's ataxia with cavus feet. #1 thing I tell the residents that I work with when I see a cavus foot is make sure you take off their shirt and look at their back to make sure they don't have a dysraphic looking spinal cord lesion or cutaneous signs of dysraphism. This child presented with a cavus foot as their main complaint, and really there's a diplomyelia and a diastatomyelia is the main source of the problem. So first think neurologic issues and make sure you don't miss that. The cavus foot non-operative treatment is not very effective because of the intrinsic neurologic issues associated with it. Typically we assess, you need to know what a Coleman block test is and what the function is. This is an example. You don't have to use a block, you can use a book or whatever's in your office. But if the foot is a tripod, the heel, the great toe, the first ray, and the lateral ray. If you can allow the first ray to fall and not have the pressure of the tripod by having the block on the lateral border of the foot, if the hindfoot collapses into valgus, as you see here, then that is a flexible hindfoot. Therefore, you do not need to treat the hindfoot as part of your problem. You need to treat the forefoot. So a Coleman block assesses the flexibility of the hindfoot and very much guides the treatment in cavus feet. The surgery options for cavus feet, a plantar release. They get a very tight plantar fascia, which helps to hold their arch up. Metatarsal osteotomies, mainly first metatarsal and mainly a dorsiflexion osteotomy because they have a hyperplanar flex first ray. And calcaneal osteotomies, if there's an inflexible or stiff hindfoot on Coleman block testing, a calcaneal valgus producing osteotomy is the option of choice. We need to avoid triple arthrodesis or fusions of the hindfoot in neurogenic or cavus feet. They have a very poor track record, typically leading to arthritic changes in the ankle joint, and then they typically have to be salvaged with pan-talar arthrodeses. A flexible flat foot with a low medial arch and normal subtalar motion and no heel core contracture is usually a non-problem or non-issue and almost always will resolve spontaneously. They do not get better any quicker with the use of orthotics. Last year that was on the test. Orthotics do not expedite the recovery of flat feet, and flat feet are typically not treated with any type of orthotics in children. Usually the arch will, in this instance, if you have them be non-weight bearing, the arch will reconstitute itself in that position. It's usually more of an educational visit than it is a treatment visit. Kohler's disease is essentially the Perthes disease of the foot, avascular necrosis of the tarsal navicular. Treat it symptomatically. What you'll see on the x-ray is a hyperdense region in the region of the navicular, just like you would see in Perthes in the epiphyseal region of the proximal femur. Typically, I will treat this in a short leg cast with minimized weight bearing to allow the foot to calm down, and it resolves spontaneously. Perineal spastic flat foot is associated with the calcaneal navicular coalition most commonly. It's the most common cause of the spastic flat foot. This is what you see radiographically, sort of an anteater sign at the distal aspect of the calcaneus attaching. It can either be fibrous or bony union into the navicular. The biggest caution I would tell you from a testing standpoint is to make sure you get a CAT scan of the remainder of the hindfoot to ensure there's not other associated coalitions. Most commonly a medial facet coalition of the subtalar joint, such as you see on the left foot in this child. The treatment for the perineal spastic flat foot, if it's isolated to the calcaneal navicular coalition, a resection is very, very successful. In the subtalar joint, if less than 50% of the joint is involved, the resection is a reasonable thought process. If there's more extensive involvement, then an arthrodesis is necessary, because if you have to resect more than 50% of the joint, it'll go on to instability and arthritic condition. Thank you very much.
Get a good review for you. We're going to start out just with the basics of MRI real quickly. In musculoskeletal imaging, we basically deal with T1 and T2 weighted images, and as long as you can differentiate between the two when you're looking at an image, then you're going to be in good shape. The T1 weighted images have a short TR and a short TE, and we call them our anatomy image. It has very high resolution, and we can see the anatomy very nicely. And the main difference between a T1 and a T2 is that the T1 weighted image, the fluid is intermediate in signal intensity. It looks very similar to muscle, whereas on the T2 weighted image, you're going to have bright fluid, and that's how you can distinguish between the two. Now, when we're looking at a MR image trying to determine if this is a T1 or T2 weighted image, the muscle is going to be intermediate. Fluid is also going to be intermediate, so if you see fluid within muscle, you won't be able to distinguish the two. Calcium would be dark, as we see here in this calcific tendonitis. Cortex is dark. The fibrous tissue, such as the labrum and rotator cuff, is going to be dark, and then the fat is bright. So our subcutaneous fat and the marrow fat is going to be bright. A T2 weighted image, on the other hand, about the only difference is the fact that the fluid is bright rather than intermediate. So if you have an image, look where there's supposed to be fluid or look where fluid might be. If you see something bright in the joint, then you're dealing with a T2 weighted image rather than a T1 weighted image. The other thing is when we do a T2 weighted image, we almost always put fat saturation on it in order to make the fluid, which is associated with pathology, more conspicuous. And so if you look in the subcutaneous soft tissues and it's dark, then this is usually a T2 weighted image that's had fat saturation. Same thing with the marrow. Okay, CT, you may see a CT on the imaging part of the exam. If you do,